Hi, my name is Patrycja. I'm a clinical nurse specialist in the area of acute pain, and I have a huge passion for education and research, application, and translation. As a person who uses science every day to help people in the hospital, I'm clearly biased, and I think science is great, and that research should be used to inform practice and to enhance health. Today, I have the pleasure of interviewing Dr. Lisa Carlesso about research innovations in osteoarthritis. Now, Lisa is a brilliant Canadian researcher at the School of Rehabilitation Medicine of Science at McMaster University in Hamilton, Ontario. She has over 25 years of clinical experience and has done a lot of fascinating work surrounding osteoarthritis pain. If you have any questions for Dr. Carlesso about her research, please email them to question@painab.ca so that she can answer them after our interview is complete. Let's start our interview. So Dr. Carlesso, thank you so much for agreeing to talk to us about your work today. Let's begin by a couple easy questions. How long have you been studying pain patterns and relationships in osteoarthritis, and what made you want to study these topics?
Yeah, so I've been studying pain related to knee osteoarthritis for about 8 years now. I started doing so during my postdoctoral fellowship, and I, had the fortunate, opportunity during that time to work with some really renowned osteoarthritis researchers who kind of really got my interest piqued in the pain processes and how complex they were. And I've had a passion for understanding pain for many years. And so it just seemed like a really interesting area and a natural fit. Also because I myself have knee osteoarthritis, and knowing that there isn't currently good pain management or a cure, then that's a big motivation.
I'd like to explore one of the things that you're known for, which is your studies of pain phenotypes. Now, when I hear the word phenotype, my mind goes to the definition that I was taught in high school biology, which was the physical expression of genes, such as eye color or hair color, for example. But that's not what you mean by phenotype. So could you tell us a little bit about what you mean by phenotype?
Yeah, so phenotypes are, I think the way that they're probably easiest to understand for people is we're not talking about genes per se, but it's more the interaction of our genes with our environment. And so what it ends up informing is a number of different things, such as our physical structure, our biochemistry, our behavior, and the way that we respond to different situations. So it's a real mix of kind of physical and biological and behavioral things.
Great, thanks for defining that for us. One of the studies that you did was basically a snapshot in time of people who have osteoarthritis. And from what I understood, you took a group of people who were known to have osteoarthritis, and you tried to find common characteristics that they might have. Can you tell us what that study found and what kind of different phenotypes that were discovered in that study?
Yeah, so I think, are you talking about the impact study? Yes, yeah. Okay, so this was a study of people with painful knee osteoarthritis. And so we use this pain phenotyping approach. So we had them answer a bunch of different questionnaires, and then we did some lab tests. And we take the results of all these, from all these questionnaires and tests, and we throw them into a statistical model. And then what that model does is it finds common groups. And we have to decide kind of what the optimal number of groups is. And so we chose 3 groups. And what we found was that they basically were kind of a least severe group in terms of the overall pain burden, and then progressively led to a most severe pain group.
I'd like to talk to you about this figure. It's a spidergram plot that you have of each of the pain phenotypes from that impact study. I thought it was very powerful visually. Can you tell us what we're looking at here?
Yeah, so these are the different variables that we put into the profiles that I was mentioning. So on the one side, you can see that there's all these self-report kind of questionnaires here. So we asked about pain catastrophizing, fatigue, anxiodepressive symptoms, how well they're sleeping, somatization, pain qualities, which is like the different descriptors that people use to describe their pain, their average pain intensity, and then the variability of their pain over the course of a week. And we also have neuropathic pain. And then on this side, the other side, we have all the lab tests, which are called quantitative sensory tests. And these tests test the sensitivity of a person's nervous system to different types of stimuli. So we used pressure, we used a weighted probe, and you can see here we have heat and cold. We used temperature. And then these ones here that say CPM, that's a test that tests how well our kind of innate modulating system is working. And so what you see quite clearly is that in this group, so that we had over 300 participants, and on this side of the chart, things are very well defined. So the self-report measures really delineated the different groups. And that wasn't the case with the lab tests. And in fact, only one of the tests, the temporal summation here, was distinct among the three groups. So that was really interesting finding to us because I had done previous work in people also with 𝐒𝐂, but who didn't have pain on a regular basis. And we saw almost the exact opposite findings, that it was the lab tests that discriminated people and the self-report did not.
Thank you. Thanks for explaining that to us. When I looked at this diagram, the things that I thought about was that we as healthcare workers should really be listening to our patients and their self-reports of their pain. I know that we're classically trained to that idea that we should believe when a person says that they're in pain and listen to their experiences. But I also know that there are people who believe that their healthcare providers are not listening to them. And to me, that work that you show here, it's very clear. People have common experiences and healthcare providers need to be listening to them. So thank you for this. I think it's very powerful and very validating. All right, thank you so much for telling us about that and explaining that diagram. How do you see your research being taken up by practitioners and policymakers, and how do you see it being used clinically?
Yeah, so I guess unfortunately the line of research isn't ready for clinical uptake just yet. It's going to take a number of years for us to develop these phenotypes and make sure that they're reliable and valid before clinicians can use them. And also, you know, we need to be able to come up with models that are clinically feasible. So because those lab tests are not available to everybody. So, but I do think that there's value, you know, if we think about the different factors that diagram showed that are affecting people, you know, sleep, fatigue, different types of pain descriptors, pain catastrophizing, all of these things can be addressed by a patient or by a clinician to try and really understand that particular person's pain experience. And, you know, is sleep an important factor? Are they having night pain? And what can we do about that? If it's not an issue, then, you know, let's talk about something that is. But you know, it's important to recognize that it is a very multidimensional pain experience, and that it's more than just asking someone about the intensity of their pain on a scale of 1 to 10.
That's great. Thank you. So you're obviously very well versed in the world of osteoarthritic pain. Do you have any advice for people who are struggling with osteoarthritic pain?
Yeah, absolutely. I think, the most important thing is that people continue to stay active and move. And I know that people are like, oh yeah, we hear that all the time, but it hurts when I move. And I know that's the case. I have knee pain myself. But what we have to realize is that by keeping moving, it helps keep us healthy. It helps us stay away from developing other chronic conditions. Because when we stop walking, when we stop being active, that's what happens. But also the movement and the exercise helps us with our pain management. Being active is social. Being active helps regulate our mood. It helps us sleep better. And all these things help keep our pain at lower levels. So there's lots of reasons to stay active, but absolutely helping with pain management is one of them.
That sounds like great advice. And like I said, not only are you very well versed, in this topic from research perspective, but also as a person who deals with it on a day-to-day basis. So thank you for that. I think that's wonderful that you're able to share that with us. I'd like to close our talk today by talking about one of my favorite parts and one of my favorite findings that you had in one of your research studies, which was the finding between optimism and efficiency with how people do with their pain experiences. Can you tell us a little bit more about that?
Yeah, so those phenotypes that we found where we showed the diagram earlier, we also looked at risk factors so what predisposes someone to being in those different groups. And we decided to include some positive traits, so optimism and self-efficacy. And what we found was that people with high levels of those things were in the lowest pain burden group, and versus the opposite, people who didn't have good optimism or self-efficacy ended up in the high pain burden group. So, we don't tend to research the positive influences, factors that influence a person's pain response as much. We tend to focus more on the negative things, but this was a really interesting finding and shows the protective effects of these positive aspects.
That's great. Thank you. And I'm sorry, I think I said self-efficiency, but self-efficacy. For me, I really appreciated that those findings about the optimism and the self-efficacy. And it just gave me great hope that we have a little bit of control over our experiences and suffering. So thank you so much for sharing that with us. Thank you for taking the time to tell us about your research. And now I'd like to invite everyone's questions. So if anybody has any questions, please email them to Dr. Carlesso at question@painab.ca. Again, question@painab.ca. Thanks.
Thank you.